Okay, good morning, everyone. Thank you, everyone, for joining today. If I can just remind everyone again to put yourselves on mute throughout this webinar. If I can just ask for the good mornings just to be paused so that they're not flicking up throughout the introductions, if that's okay. But it's a really good morning to you all, and thank you so much for coming to this webinar. So my name's Camella. I'm consultant midwife at East Midlands Ambulance Service and lead midwife at London Ambulance Service. And I'm presenting today with some colleagues who will introduce themselves shortly. We've all been involved in writing and updating JRCALC guidelines for maternity and newborn care, and we're going to share those with you today. This webinar is being recorded. If you're watching it on catch up, I would recommend that you put it on 1.5 speed, just because of the way that we might be presenting. So the National Pre-Hospital Maternity and Newborn Care Group is a group that feeds into NASMED, the National Association of Medical Directors, and we have been doing the reviews and updating the guidelines, and I'd like to thank all the people that have been involved in that, a few of who are presenting today, but there are many more people that have been involved. And this is the first time that we've done one of these national webinars following updates to maternity guidelines. So we will ask you to do an evaluation at the end, and we'd really like to hear your honest feedback as to whether it's been helpful or not. The webinar is a national webinar, so we won't be pointing out regional differences in this webinar, and we would urge you to seek out what your regional guidelines are where relevant. Just to say that this webinar is for ambulance clinicians who use JRCALC. If you're not an ambulance clinician, you are welcome to stay, but the content might not be relevant to you. There will be a webinar for people that are not in the ambulance service around the maternity decision tool on the 27th of November, and we will be disseminating the link to that shortly. We will cover some challenging topics in this webinar, and we understand that maternity care is often challenging for ambulance clinicians for a wide range of reasons. And so please be mindful of your wellbeing throughout this webinar. It may trigger personal or professional experiences that you've had. And so please be mindful of it. And if you need to step away from the webinar at any point or seek wellbeing support, please do so. And we will be using real cases from around the country, which have informed some of the guidelines reviews. We're absolutely not presenting any of those out of criticism to anyone involved. In fact, much more sympathy to anyone that was involved. But the cases, we want to use them in a good learning environment to demonstrate the positive impact that good learning can have to prevent future cases happening. And optimise care. I'll just ask everyone just to put yourselves on mute again.
Sorry, I've already done that, darling.
Somebody's just not on mute. Oh, thank you. So you're welcome to use the chat for comments through the webinar, although what I would say is that we will have a Q&A at the end, and there will be the opportunity to ask questions anonymously as well. So we will save all the questions to the end. And please, can I really ask no one to download this webinar, because we only get one chance to download the recording, and that needs to be us so that we can put it onto a public platform for people that can't attend today. So please don't download this webinar afterwards, and that needs to be us. And again, I'd just like to acknowledge that there's been so many people involved in these guideline updates, and thank you to them all. So I'm now just going to share my screen and walk you through just a few of the guideline updates that have already come in, before we talk about the ones that are going to be launched on the 21st of October, which is next Monday. Now, just to say where there are organisational badges on these presentations, that's not to say that these organisations have endorsed it, but just to say that there has been stakeholder engagement from individuals that represent in those organisations. Can one of my colleagues just say whether you can see those the slides?
Yeah, we can see them, Cam.
Yeah, brilliant, thank you. Okay, so just very quickly then, So these are the 4 guidelines that have been updated in the last year. What I would say about the updates to JRCALC guidelines is that what we're really striving to do is to make the algorithm for each guideline as strong as it can be, so that you, in the heat of the moment at 2 a.m, when you're faced with this challenging situation, you can get up the algorithm and everything that you need to know is there for that moment. The guidelines, we've tried to streamline them so that they're not textbooks. Anything you don't need to know is not in them. But I would really urge you to use the algorithm. There are a few QR codes as we go through, and you're welcome to scan them if it's helpful, and save the link for viewing after the webinar. So the first guideline, and thanks to everyone that was involved in this update, there's a few of the things listed on the screen as to what has come in. Into the guideline, so what to do in terms of foot or feet presentation, when we stay on scene with a breech birth versus when we need to go. This thing about hands poised is really important to note from the new guidelines. So we used to say hands off, we now say hands poised, and there's very specific scenarios in which we actually need to put our hands on. We need to apply a 5-minute timer from when the buttocks are delivered, and you see a picture of that there on the screen. And the whole baby needs to be born within 5 minutes. We also need to recommend that the woman continuously pushes from when the buttocks are delivered. The guideline also has on the algorithm pictures of the different positions, with mum on in a supine position and mum on an all fours position, and it shows you the different ways that you would then help to deliver that baby if required. So take a look at the algorithm for that. There's also a new maneuver, which is the shoulder press, and there are videos that are embedded within JRCALC. In terms of bleeding up to 20 weeks, the main headline is around ectopic pregnancy, and we will talk a little bit about embrace in shortly, but there is a kind of focus across the country around detecting ectopic pregnancy. So have a look at that. And we've also included management of excessive bleeding after miscarriage, and various bits from the new NICE guidelines have been included in the bleeding in pregnancy up to 20-week guideline, and that came out on the 4th of January this year. This one is an absolute key one to remember, to think about, is the bleeding in pregnancy over 20 weeks. And again, as I said, all you need to look at is the algorithm. It's time critical for every ambulance clinician in the country. If you go to someone that's bleeding after 20 weeks, whether you've seen the bleeding or it's reported by the woman, that's a time critical situation for us, because there may be a number of differentials, but we cannot stand down that or de-escalate that care in the pre-hospital setting. Postpartum hemorrhage was also updated and released on the 4th of January. And really the main headline here is use the algorithm. Again, as you see it on the right hand side, do everything on the algorithm for all PPHs. It's a package of management. And you see the emotive acronym there, in terms of what we want to be covered for every PPH. And we can do further webinars on that if it's helpful. It's a package of management, and we do the same management whether the placenta is in, the placenta is out, primary or secondary PPH. It's all patients meeting PPH criteria, even if the bleeding then stops or ceases. So I'm now going to hand over to Susie, who's going to present on, and Gavin, who are going to present on imminent birth.
Good morning, everyone, and welcome. Thanks, Cam. Good morning, everybody. Really warm welcome to you all. Lovely to see some familiar names and faces. I'm just going to find the presentation, and then I will just again request one of my colleagues to ensure that we are seeing what we need to see. Just bear with me just a moment.
You can see it.
Thank you, Dawn. Okay, so we've updated the imminent birth guidelines. We did have some previous guidelines around managing birth, but we've recognised actually that our workforce and the services that we feed into have also ultimately changed, and that some further guidance is needed for our clinicians who are managing birth on scene. You can see that the 4 main authors are on the screen at the moment, but this is also largely due, we've also had large stakeholder engagement, and many thanks to anybody and everybody who's contributed. So it wouldn't be a JRCALC guidelines without the algorithm. We do have an algorithm embedded into the new update as well. I won't go through the algorithm at this moment in time, but this guideline will give you a feel as to what is going to be available to you when you're facilitating the birth on scene. So in the guideline, we are focusing on a head-down birth. So we're not in this guideline, we're not talking about breech, where you have your own breech guidelines to deal with that. So what we are wanting to look at is thinking about when we first getting on scene and taking a history, and the guideline provides you some questions in order to guide that history taking. We do emphasize the need for an interpreter because we realize that there's lots and lots of non-English speaking patients that we see too, and this is often seen as, in our cases, as quite challenging. And what we don't want to do is exclude care. So here are some, initially you'll be reminded to seek an interpreter if you require one, and here there will be also provided some questions that can guide your history taking. We provide information on how to assess a contraction. We do realize that, you know, many ambulance clinicians have limited amount of maternity training and education through their either the higher education or the vocational training or even their CPD. So we do provide some information about how to assess a contraction and when you actually need to think about leaving scene immediately. We've acknowledge the fact that the decision making on when to stay and when to go is difficult. So we've provided some guidelines about what we would require as a time critical conveyance. So of any of these aspects that you're seeing here, and you can see obviously that there's a bleeding up to 20 weeks, aligns with your other guidelines as well. So we'll give you some, in your guidelines, there are some good examples of what we'd expect for you to think about what a time critical conveyance would be, and we'd expect you to immediately leave scene. It comes with a caveat that obviously if the baby is imminent, if the birth is imminent at that point, then that takes precedence over any other risk that you might be seeing. So what is it? How do we know if the birth is imminent? And how do we know if we're going to stay on scene? So if we're looking at the decisions to stay on scene, we want to think about patients who are contracting at 1 to 2 minute intervals and have an urge to push, or we can see a presenting part visible as well. So the presenting part visible might be a head, it might be anything else, it might be a bottom. In this case, we'll focus on the head. But if you're starting to see a presenting part visible, so what we mean by that is, obviously as part of your assessment, you will need to gain consent to actually have a look at the woman's vagina. We need to see if anything is coming out at this point. If you're determining that something is coming out at this point and it could be a head, then we are going to stay on scene at this point. It's very important how we understand what we're seeing. So the presenting part could be, in this case, the head is coming, we're starting seeing the parting of the labia as well. This will continue to progress, hopefully. What we wanted to see is we wanted this to continue to progress. And you might see that the head coming and going slightly, and that's between the contractions, and that's completely normal. Once you start seeing crowning, that's when the head remains visible and doesn't slip back between those contractions. The important thing is that we're seeing this continuous progression. We want to ensure, and on your algorithm, we will also have reminders that you're going to be undertaking a continuous dynamic assessment. We need to ensure that this birth is actually progressing. If you are seeing the same part for all the way through those 10 minutes, then this is the time to leave scene. We need to ensure that the birth continues to progress, and how we're going to keep doing that is we're going to keep looking and we're going to keep assessing. If we continue to see progress, then stay as you are and prepare for birth. If you're seeing exactly the same part, we're not seeing any progression, then this is a time critical emergency, and that's one of the pivotal changes that we've put into this guideline. have provided some information about how you're actually going to manage the birth and the initial steps that you're going to take. We've always said call for help. In this instance, what we're hoping to do is we want you to call for help from within your ambulance services. So think about having extra resources available to you. What we're anticipating is having an ambulance clinician per patient. We particularly want a paramedic per patient if possible. You can think about using critical care as well if that's appropriate. But the only time where we're thinking about actually requesting midwives to come and help facilitate the birth, if this is a planned home birth, then it's absolutely appropriate to contact the patient home birth team in order for them to help facilitate the birth. We must recognise the fact that actually midwives are coming to us on normal road conditions. So we still need to prepare to be able to facilitate the birth in the absence of a midwife. So part of your care is also outlined. We're asking you to introduce yourself to teams. Introduce yourself to the patient, but you would do this anyway in most of the cases that you go to. We're asking you to empower the patient to move. So we want the patient to be able to move around in order to be able to find the most comfortable position for themselves. Now, this is fine when you're at home, but it might be slightly more challenging if you're on the ambulance. We do recognise the fact that sometimes we make the decision to leave and a baby might be born in the ambulance. And in this case, we're stopping, we're pulling over, and we're facilitating the birth in that ambulance and calling for extra resources because you'll immediately have 2 patients there. As we're continuing, we are emphasising the fact that you need to observe the sign of progress continuously. And obviously, offer Entonox to assist with any pain relief that the patient may be having. Your environment is going to be particularly important, and what the most important thing for yourself will be so that you can see what you're doing. We understand that when that people who are having babies, having a nice dim environment is really good for a physiological birth. However, we do need to be able to see what we're doing. So ensure that you have adequate lighting in order to be able to help the patient. We need to get the temperature up as high as possible. So whether you're in the ambulance or in the house, get the temperature up, get the heating on if that's available to you, and close all the windows and doors. Get rid of any drafts that we can have. And if you are in the ambulance, then try and limit the amount of times you open and shutting doors. We need to keep the heat on in the ambulance. Now, operationally, we know how uncomfortable that can be, but really, if the heat's a little bit too much for you, then that's probably just right for when the baby is born. The immediate equipment that you're going to need is plenty of dry towels. You might need to be able to facilitate this by bringing in your maternity packs, which has at least two dry towels in there. But if you can use further dry towels in the house, all the better. The more dry towels you have, the better. You don't need to worry about warming these towels. They just need to be dry. You should all have thermal mattresses available to you as well. So these are newborn thermal mattresses that you can slap the tab, and they warm up pretty quick to about 40 degrees. It's really important that if you are placing babies on these thermal mattresses, that you have a towel between the baby and the thermal mattress as well. And of course, all your maternity packs will have a hat in them. When you're thinking about your equipment, having a support station would be really, really beneficial because you don't know what condition that baby is going to be born in. So set up a newborn life support area. It needs to be a firm, flat surface. Think about the neonatal masks that you might have. So within your pediatric BVMs, you will have 2 size masks that come in there, but think about the size 0 and the size 00 masks as well, because you might not always know the gestation of the baby that it's about to be born. And you'll definitely need a stethoscope in order to listen to the baby's heart rate. So as we support in birth, we are thinking about exactly what Cam has just said about this hands poised. So we're not putting hands on and we're not hands off, we're just ready. At the point of crowning, we're encouraging the patient to push through, and in order to slow down the birth of the head. And we're hoping then to see that the body is born within 2 contractions of the birth of the head. If the cord is around the neck whilst the baby's being born, that's absolutely fine. Leave it there. And once the baby's born, then we can start unlooping it. We've moved away from immediate cord clamping, and we're talking about optimal cord clamping instead. So we're going to keep the cord intact for the first 60 seconds, in many cases, as much as you can. And this is when you're drying and assessing the baby. It takes 60 seconds to do that, to leave the cord alone. Let's take away that, any complications about that. Take that out of your mind and leave the cord there. If the baby is well, and we'll show you how to assess a baby, then keep the cord intact until this has gone white. The only time what we're putting there for you to immediately clamp is if the cord is snapped, and at which point, if the cord if the cord is snapped at the baby's abdomen, then we can apply pressure to the baby's abdomen, and that's a time critical transfer. If the cord prevents the baby from being held closely to the mother, then basically we'll give that cord 60 seconds and then we'll clamp and cut. And if there are multiple babies, then at each point, the baby, we might not, if we know that there's another baby to be born, the firstborn baby being born will have immediate cord clamping, but we'll allow optimal cord clamping for the second baby.
Susie,
yes.
Sorry, Susie. They're just saying that they can't see the slides changing. So I'm just wondering if you could unshare and then reshare to see if that works.
Sure,
Thank
sorry.
You.
I think it's just for a couple of people, Cam. So I'm trying to sort of let them know.
Everybody else
okay, it's working for. Okay,
great.
Let's continue.
We're on slide 13.
We should be on 13. All right.
You could move it yourself. Yeah, that's perfect. Thank you.
No problem. Thanks, everyone. We're getting a lot of comments on it now. Thank you very much. Okay, so we provided some pictorial images on how to actually clamp and cut the cord, because we understand sometimes that this can be a little bit of a minefield of trying to remember how far away you need to cut from where. So basically we simplified it, and what we've suggested is the first clamp is 5 centimeters from the baby, the second clamp is 5 centimeters from the first clamp, and the third and then you cut between. There's not the third clamp. So you can see images there that we've provided, which should be nice and clear, and just be careful not to cut any genitals or fingers. So we're going to move towards a newborn assessment at birth. Now, we've removed APGAR. Okay, so APGAR has been taken out of the JRCALC guidelines, and instead we're now utilising methods which are aligned to the Research Council guidelines, because this helps to recognise the need for the intervention for the newborn. So initially, we're going to look at the colour, the tone, the breathing, and the heart rate. So the colour and tone are going to be almost immediately visible to you. We expect him to see a bluish hue on most babies, but actually looking at the mucous membranes will give you a good indication as to whether there's some cyanosis there or not. We want a nice flex tone in the baby, and we're looking at a breathing rate between 40 to 60 a minute. But if we're seeing good effective breathing and a nice loud cry, then we should be pretty happy. Essentially, the baby's heart rate is going to give us a estimate of how well that baby is. So if we've got a nice fast heart rate, then we're happy. But we will provide you those guidance there, and that's in the table in the new guidelines for you. The third stage is obviously between when the baby's been born and the placenta is being born. Okay, so we've given some information about how you're going to manage that third stage now, and any and review any bleeding subsequently. So what we want is anything that the mother's birthed the baby on at the moment is to replace the Inco sheet on the mother, so that you can start seeing if there's any bleeding that's coming through it, and that's something that you can take away with you in order to measure the blood loss later. We're going to record all the clinical observations for both mother and baby, and we're going to monitor signs for PPH. Once the baby's been born, and if you haven't got a midwife with you, we would like to think that you are starting to think about leaving scene and going to the hospital, because we cannot diagnose third stage complete. We are not in the ability to be able to assess the placenta, and we're not able to assess the blood loss. So if the placenta is still in situ within 20 minutes following birth, then we need to start taking the time critical conveyance to hospital with a pre-alert. We're talking about skin to skin because it's really important that we think about the thermoregulation and also the patient experience. So once the baby's dried, it can be held to skin with a warm adult. In most cases, it will be the mother, but if she's not well enough, it can be held skin to skin with another warm adult. So we've provided a image in the guidelines in order to show you how this looks, and also we think about how you're going to apply a hat, and you can apply a thermal mattress over the baby as well. There's some changes that we'll make if we're thinking about having a preterm baby, if we're with the preterm baby, and basically what we think about, if the baby's under 32 weeks or small enough to fit in a plastic bag, then we're going to put a baby in a plastic bag as well, with the head exposed, wrap the baby up as you would normally, hat on the baby, and then onto a thermal mattress. These babies are particularly in particular danger of a higher mortality rate if they become cold. So the thermal regulation is really, really emphasized. We've discussed in the guidelines about what to do around multiple pregnancies as well. I'm not going to go through all the special considerations step by step in this, because this is all covered in the new guidelines and will be available to you in its own subcategory. But every single time you need to think about whether you need more help. And if you have a multiple pregnancy, then you're going to have multiple patients. So you probably do need more people to help you out. We're also going to talk about an amniotic sac presentation. So basically, we'll want you to undertake a time critical conveyance to the nearest maternity unit. And if the sac does burst at any point, then you need to start going back to thinking, is birth imminent, and what are we going to do about it now? And you can go back to your guidelines to be able to manage that. Some babies are born in the sac, an on-call birth. And basically, once the baby is born, we will break and remove the sac. And we provide some more information in your guidelines about how to do that. Some of our patients have a planned home birth and will have a birthing pool. We are not training you how to birth a baby in a pool or facilitate a birth in a birthing pool, but we are going to ask you to ask the patient, the mother, to get out of the birthing pool. And there's some information in your guidelines as well, whether if somebody decides actually they wouldn't like to get out the pool, and it provides you some information about what you need to say and how you're going to kind of organize your resources in these situations. Some people will decide to birth without any trained healthcare professionals, and it's a perfectly legal right for a woman to birth without the help of anybody else. If you are called to these cases, we do urge you to call for maternity service for a face-to-face handover. So in part of the JRCALC, it will be that if the baby is born, then a midwife will be required for a face-to-face handover of care.
No.
When we are conveying to hospital, we do want clinical observations frequently. This will all be listed in your algorithm. Wherever possible, the baby should be secured in the ambulance. We appreciate right now that there's some challenges to this, but we are asking that car seats aren't used for preterm or vulnerable babies. This is because not everybody is always used to using car seats. We can't always measure how well that baby is doing, and sometimes we can occlude airways for preterm babies that don't always fit as well as we'd like. We'd like to ensure, where possible, that mother and baby travel to the same hospital, and we have the ID bands that we'd ask you to use that are in your maternity packs. We want at least 2 sets of observations on each patient, and Cam will go on to speak about the pre-hospital maternity decision tool, so that you can determine the well-being of the mother. Thank you for listening, and I'm going to pass you on to Gavin now, who's going to provide a case.
Good morning, everybody. Hopefully you can now see my screen. It should say case review. Yep, excellent. Okay, so this sort of will give you an opportunity to have a think about what Susie's just been through, and how aspects of this of the new guidelines might have affected this particular case. It is from London, but hopefully it's all anonymised, and so it shouldn't breach any confidentiality. So this was a call to a 21-year-old with her first pregnancy, and she was already at 41 plus 2. She had been booked for an induction the next day, but she spoke limited English. Gujarati was her mother tongue. So again, we're looking now, this would really require that use of the interpreter as soon as possible. She'd been prescribed iron supplements for low hemoglobin, but she had no other complications. At 40 plus 4, she attended her booked unit for an assessment of her labour and was discharged back home. And then 3 days later, at 41 plus 0, she attended the booked unit with a history of back and abdo and leg pain and some urinary symptoms, but discharged home again. On the day of the attendance by LAS, the husband called 999 and reported that the baby's head was visible. This triggered a Category 1 response, and the first resource was on scene 4 minutes from the call. Initial assessment was that the woman was lying on her back in bed and appeared comfortable. Fetal movements had been reported that afternoon, and no blood loss, no PV loss had been reported. The attending clinician did note an unusual shape to the abdomen, that it was distended at the umbilicus, and there were no presenting parts visible at the vulva at that time. The patient reported difficulty in passing urine. The clinicians were having difficulty in assessing the contractions, but they did manage to give pain relief for the patient via Internox. So initial set of observations that were recorded were rests at 28, heart rate of 138, BP was 133/94, SATs of 97, temp 37.3, blood glucose 9, and GCS 15. At this point, the clinicians rang the booked maternity unit to discuss their concerns and requested a midwife to attend. They also had called the clinical hub to assess where the nearest maternity unit was, as opposed to what might be the booked maternity unit. At this point, the vertex became visible again. Obviously, remember that the husband had reported being able to see the head. So again, on the phone, at the nearest unit, they had a discussion with the triage midwife regarding the progress of birth and their concerns. Now, at this point, it is now 30 minutes since vertex was first visible. At this point, the crews make the decision to convey to the nearest obstetric unit with their clinical concerns and lack of progress. The woman declined being conveyed to the nearest obstetric unit, but I think the crew overruled that. The crew walked the woman to the front door and transferred to the ambulance via the trolley and conveyed to the nearest obstetric unit, where they are met by the triage midwife and a junior doctor. Using the CTG machine was declared pathological with a diagnosis of obstructed labour. The mother was catheterised and 1.5 litres of dark brown urine drained. Bilateral episiotomies performed, and roughly 2 hours after the 999 call, a spontaneous vaginal birth of a live female infant. The notes note that there were meconium, an offensive liquor, and lots of pus noted. The body weight was 3.7 kilos with an APGAR of 256. And you can see the arterial and venous blood gases there. Unfortunately, this baby needed intubation at 20 minutes of life and was then transferred to the tertiary unit for therapeutic cooling. The baby had a diagnosis of persistent pulmonary hypertension due to meconium aspiration, and an HIE of 3. That's the hypoxic ischemic encephalopathy, and that leads to about a 75% mortality at that level. The mother was diagnosed as a major obstetric hemorrhage, losing 3 litres of blood, concurrent with sepsis, and required an ICU admission. So as you can see, it was a number of factors, obviously most of them outside of the control of the attending clinicians. However, the time from 999 call to conveying that patient to the hospital will have had a significant impact on that baby's outcome and the resulting implications for future care. I'm going to pass you back over to Dawn now, I think.
Many thanks, Gavin. Okay, let me just upload my presentation. So I'm going to be talking about the changes to cord prolapse. And if someone could just let me know if you can see my slides.
We can, but it's not on presenter mode yet.
Okay.
Yeah, perfect.
Okey-dokey. So let's just have a quick reminder of what cord prolapse is then. Cord prolapse is when the membranes rupture or the waters break and the cord slips out ahead of the baby. And then obviously if the baby follows it, the baby mechanically will cut off its own circulation. And then furthermore, if the cord is outside of the woman, it's subject to getting cold or being handled or touched. And so that also poses a risk to the baby. So it's not very common. It happens in about 0.1 to 0.6% of births, and that evidence is from the Royal College of Obstetrics and Gynecology. And it's more common in breech births or transverse lie. I always describe a transverse lie as a baby that is laying across the woman, like if you saw her in a supermarket, it would look like she swallowed a boomerang. So essentially, there's nothing in the pelvis to stop the cord from swishing out. If you've got a head in the pelvis, that acts as a plug. So what have we done? What have we changed? So we went all around with this guideline because currently it says that if you come across a woman who's had a cord prolapse, that you should insert the cord back into the vagina. We have now removed that because we found no evidence for it. And we think that probably historically a consensus opinion was made, but there's actually quite strong evidence now to suggest that we shouldn't be staying on scene with this. Because this is a case, let's think about this, where you probably see this once in a career. And the thought of having to replace the cord back into a woman's vagina is already quite, horrifying. But to then have to do that in a time critical situation, we decided to remove it. And so the algorithm is as follows. We're going to ask you, as always, to review your JRCALC obstetric guidance if you're not driving, to try and achieve a shared mental model. We're going to assist the woman to wear her underwear and a clean, dry pad, which will hopefully contain the cord and cradle it against the woman's external genitalia whilst conveying into hospital. If the woman has already gone through pathways or MPDS, then hopefully this picture of this woman in what we consider the exaggerated prayer position will be what you will meet when you arrive on scene. The woman should already be in this position if pathways or MPDS has been followed. And you'll see from that picture that the reason we ask women to do this is because all of the weight of the baby is down near her chest. So that prevents the cord from being crushed. If she stands up, you'll note that immediately the cord there's a potential for it being crushed. All of this, it's worth saying, is us guesstimating, I suppose, for want of a better term, because we haven't got a scanner, we can't see what's going on in there. So we're doing this to cross our fingers and hope for a good outcome. So then we're going to walk the woman to the ambulance. Now, this seems a bit bonkers, given that I've just said we don't want to stand the woman up, but actually we need to think about the fact that this is time critical and we don't want to delay time on scene. So actually the quickest way to get the woman out is to walk her with haste. So I often say to my colleagues at CCAM, this is a conversation before you leave scene. This is really about saying to the woman, we're going to get up. And then as soon as you're upright, we're going to walk very quickly to the ambulance. And then when we're in the ambulance, we're going to pop you on your side. What we don't want to do is for you to have a chat with the neighbours if they're out, cutting the grass or anything else. So this is a real emphasis on walking the woman with haste to the ambulance. And then we're going to put the woman on either side and try and get her sort of, I try and say to my colleagues, try and sort of push her so that she's almost on her front, put something under her hip so that all the weight is kind of into the trolley, as it were. We used to say left side. The latest evidence is suggesting it doesn't matter if you go left or right side, so that's absolutely fine. And I always try to put women on their right side so that I can talk to them and reassure them. And I think we all feel like that, don't we? Keep a woman so that you can see her. Obviously, we're going to assess for imminent birth all the time en route, and that will require you saying to women, do you mind if I have a little look just to see that the baby's not coming? And if she's contracting, by all means, give her Entonox. Quite often, cord prolapse happens without labour, so don't be worried about that. If that happens, that's quite normal. So what have we done then to change it? We have said you don't any longer need to put the cord back in, and we have really tried to emphasise in bold here that it's time critical and don't delay on scene. So we're now in the ambulance on our way. Hopefully you are aware of your geographical consultant-led units or labour wards, for want of a better term, and you're going to give them a pre-alert. Taking this to a standalone birth centre would be bad, and that's kind of applies to all maternity emergencies, because ultimately this woman needs an operating theatre, an obstetrician and an anaesthetist, none of which you will find in a birth centre. So I'm just going to run through quickly a case review of a patient that we had recently, and then I'll explain why I've chosen this case afterwards. So this was a 31-year-old female who was term +4, and at 6:40 in the morning they made a 999 call to say that the waters had broken and that the cord had slipped out. And this is automatically a category 1. And they were assigned a vehicle at 6:41, and they were at scene, the crew, within 3 minutes, which is outstanding. They were obviously not far away. And then they left scene by 6:57, and they were at hospital at 7:01. So if you just look at those timings, I think we all agree that they're timings that we would all be quite pleased about, and we would be, happy to see those in a case review. Thankfully, Mum lived on the ground floor, and when the crew arrived, she was naked on the bathroom floor with her bottom in the air, as per that previous picture. The cord was touching the floor and was estimated to be about 8 inches long. So I just want to think about that for a second, because that's unusual to have that much cord out. And this crew considered and tried to put the cord back in, but obviously there was too much cord to attempt to do that. So they got to hospital, as we said, and the baby was delivered and had full newborn life support resuscitation. And then the baby went for what we call therapeutic cooling. And for those of you that are unaware, this is what we do with babies that are potential for neurological damage. And it's to basically try and prevent that. But unfortunately, when this baby was warmed and scanned, they decided that this baby had significant HIE, and care was sadly withdrawn. So based on either guideline or guidance, as in the previous guidance or this guidance, I would actually say that was good care, because this crew did consider trying to replace the cord, and for whatever reason they were unable to. What I would say is document that in your notes. If you've considered anything, and this applies to all maternity emergencies, if you've considered anything, please document that you considered it, even if you didn't do it, because if this becomes a legal case, then we can say that that was then thought about. So this was a logistical issue at this time, because they couldn't get the cord in. So I think that made me think about the fact that this could reoccur, and how creative you all are in how you manage things. And don't let that ever stop, even though it's a maternity emergency, because in this instance, I think I would have probably got a hand towel or something, a piece of clothing, and I would have made a sort of sling between her legs, just to hold the cord, just to carry it out. What we don't want to do is touch it too much, because it can spasm. So actually just cradling it in something soft like a towel and sort of holding it between her legs to get out might be something you would consider. The other thing just to say, which I forgot to say earlier, is with all of our new updates, we're trying to make specific tiles so that you can just see very quickly when you go onto JRCALC Maternity, oh, cord prolapse. You haven't got to look through something else to find it. So cord prolapse now has its own standalone tile. So thank you very much. I shall stop sharing. So just to summarise once more then, this particular emergency, we are no longer replacing the cord in the vagina, and we are leaving it either in a pad into the knickers, or we are slinging it in a towel to try and get this woman out. Thank you very much.
Thanks so much, Dawn. Can you just confirm you can see my presentation?
Yes, we can.
Perfect. So now I'm talking about a new guideline, which is coming in, as I said, on the 21st, on Monday. I'm just pausing because I can see somebody's got their hand up, but just to say, is that because you can't see the slides? I'm going to continue. If it's a question, if we can just take it at the end, if that's okay. So this is a new guideline which is coming in, and it's for ambulance service personnel to use only. And there's been a massive amount of stakeholders involved in the production of this guideline. And there was a core group of us, of 9 of us from 9 different ambulance services involved in the task and finish group, which is continuing, which I will talk about. But then we consulted with over 100 other stakeholders from a breadth of places, as you can see on the screen. So as well as service users. So why do we need something different? So why do we need this guideline? So what we know about pregnant patients is that they can get sick and deteriorate, and they can compensate for a long time, and so we can easily miss them. And that's because of their altered physiology, which is beyond the scope of this webinar to discuss in detail, but we'll come on to talk about that a little bit more. But essentially, because they compensate, they sometimes only show marginal clinical observation changes, which may be normal in non-pregnant patients, which as ambulance clinicians, you'll be more used to seeing patients that are not pregnant. The other thing is that the differential diagnosis in pregnant women can be quite varied, and they may be physiological in etiology, but it could be that the observations are altered because of a pathological reason, which is very hard to exclude in the pre-hospital setting and impossible in some situations. And we need to exclude those in order to save lives. And there's lots of reports that show that. The other thing is that we can do observations on mum, but we can't do observations on baby in utero in the pre-hospital setting, which I know sounds obvious, but that's really important because actually the mum is like a proxy for the fetal environment. And so where the mum will show subclinical signs which relate to fetal concerns, we're not able to pick those up in the pre-hospital setting. And that's why we need this decision tool. Essentially, the overarching thing is that we need to give ambulance clinicians something that enables them to do an individualized and specific assessment. So I would just issue another trigger warning here. I'm talking about here the Embrace report. Embrace stands for Mothers and Babies Reducing Risk Through Audit and Confidential Inquiries. And it's an organisation that looks at all maternal deaths that happen in the UK, and they release a triennial report where they look at thematics across different groups of causes of death. And so we are now assessing the pre-hospital aspect of that care, and this report was released last week. So you can see here that now the biggest cause of death, the most amount of women that die, are from blood clots. And as you can see here in the middle, 1 in 4 of those women died from a VTE in the first trimester of pregnancy. And this is, I flag this to say, with regards to this and ectopic, sometimes we might not know that they're pregnant, or they might not disclose it, or it might not be immediately obvious. So whenever attending a woman of childbearing age, please consider whether they could be pregnant. And that is really important in terms of using this tool, which I'm going to talk about. You can see there's other significant reasons why women will die in pregnancy and shortly after birth. And I'll just bring to you a few other headlines. So 70% of these women died in the postnatal period, which is also a really important point to notice, because if we think about the use of this tool, which I'm going to go on to show you, is really important that we don't treat postnatal women the same as non-pregnant members of the public who haven't been recently pregnant. So postnatal care is really important. And again, it might not be immediately obvious that somebody's postnatal, especially if they've had a miscarriage, a baby loss, or there might be safeguarding issues as to why their baby is not with them. So please also use your respectful professional curiosity to understand whether somebody may have been recently pregnant. We also know that there's discrepancies or inequalities for Black women and Asian women, as you see there. And this statistic here, 3 times, people will know that a few years ago it was 5 times and then 4 times and 3 times. But actually that reduction is only due to the fact that there's been more deaths in white women rather than a decrease statistically across time in the deaths in Black women. So this is a really important thing to consider. Purposeful care when providing care to women from global majority backgrounds. It's beyond the scope of this webinar to discuss that in depth, but I did want to highlight that to you. And you see there in terms of the most deprived areas, women that are older and obese and of multiple disadvantage as well. In terms of, on the right-hand side there, cardiac disease, sepsis, neurological conditions, I just highlight them to say that all of those cases have been considered within the production of this tool, and that QR code in the middle will link you to the latest report. However, you can just find it on Google very easily. So what happens in pregnancy and postnatally to a woman that means that we need to treat her differently? So you can see the table here, all the hematological differences that happen. And there's lots of really great papers on this that you can find online. But just to say that this is why we need to treat them differently. They've got more blood, the makeup of the blood is different, the way that their heart is pumping is different, and the hormones that are circulating in their body. But it doesn't just go back to normal just straight after the placentas come out, as I've said. So that's why we need to treat postnatal women with a difference as well. So you'll be used to News 2, which is what you use to assess your adult patients in general. And here we're just comparing what News 2 is to Muse. So Muse is the maternity early warning score parameters, which they have recently been updated and are being rolled out into the hospitals, the acute settings in due course. They're in 15 units at the moment as a pilot and will be going further. But essentially, there's some large populations data studies which have enabled us to understand what are the correct normal parameters, for a pregnant patient or recently pregnant patient. And so you can see here that if we use News 2 in pregnant patients, then we may miss some of the tighter normal ranges that exist for pregnant and recently pregnant patients. And the Royal College of Physicians said this in 2017 and said, you know, News 2 shouldn't be used in pregnant patients. And what we're telling you today is that we're now giving you something to use instead of News 2 for pregnant patients when you're seeing them in the pre-hospital setting. So I'm just going to run through a few incidents, and we could have selected loads, and these are from around the country, and again, not out of any criticism, but just to demonstrate why those tight margins are required when assessing a pregnant or recently pregnant patient. So this woman, and obviously I've not included loads of the detail to the case, but just highlighting so you can assume that everything else was normal in these cases, and just the things that are highlighted were in amber. So these are where I've put them in amber. These will be amber on the decision tool, which I'm about to show you. So her respiratory rate was 24, and her heart rate 114, which for News 2 does actually give a score of 4. by the way, all of these incidents, there was a theme across them all, in that the timeliness of the conveyance was an issue on review. So that's again important to note. She had, on arrival to hospital, essentially she'd had a concealed APH, 1.4 litres in her uterus, and in total she lost 4.6 litres of blood. The baby required newborn life support, and actually they did make a full recovery, both of them, but with significant protraction of the hospital stay. So just one to consider in terms of, just to demonstrate, you know, those marginal changes in the observations. Actually, everything else was normal when that crew assessed that woman, and those were her observations, and that was the outcome. And it could have been very different. This was a lady, it was 26 weeks. Her blood pressure was 145/98, which for a News 2 score is 0. And she was, that everything else was normal for her. She actually had a seizure on arrival to hospital. Again, the arrival to hospital was delayed, was a protracted conveyance. The baby was born by cesarean section. She went on to have, she had actually already HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. And it's kind of an end stage of preeclampsia, or eclampsia in this case. And she went on to develop DIC as well. She was in ITU for 10 days, and the baby was in NICU for 8 months. That would be quite common for a baby to be in NICU for an extended period of time, obviously being born at 26 weeks by cesarean section. However, there may have been an opportunity to get this woman there earlier, and really this is to demonstrate the fact that that blood pressure is not, according to News 2, is not of concern, but in a pregnant patient absolutely should be. At 36 weeks, this lady had an 80 ml APH, which had then stopped. The bleeding had stopped. The News 2 score was 0. All of her observations were normal. On eventual arrival to hospital, the fetal heart rate was bradycardic. She required a category 1 cesarean section, and they were unable to resuscitate the baby. And really, in this case, even 10 minutes would have made a difference. Could have made a difference, I should say. And the thing with this case is that to demonstrate that bleeding in pregnancy over 20 weeks is a red flag in and of itself without any changes in observations, and even if the bleeding stops. This lady at 37 weeks, her temperature was 37.7 and her heart rate was 114. So that's one red flag and one amber flag. Her News 2 score was calculated as 2. Her situation was that her waters had broken, but that was difficult to determine from the history. She had a category 1 cesarean section for fetal hypoxia on arrival to hospital. It was actually chronic hypoxia that was shown on the monitoring, which is where basically the variability on the monitoring that we do on the baby's heart rate is significantly reduced for a substantial amount of time, which shows us that their brain activity is not what it should be. This baby was treated for sepsis for over 5 days and did make a full recovery, but had got sepsis, significant sepsis. So this is really to demonstrate, so a low-grade pyrexia in a pregnant woman is a red flag, and this is mainly because of the chance of chorioamnionitis, which is a condition where the waters around the baby, or the amniotic fluid, or the membranes, or both, are infected. And what we can't tell that, but what the woman shows is like subclinical signs. So we have a low-grade pyrexia and sometimes some tachycardia as well. But that's why on the tool, a low-grade pyrexia is a cause for concern. And this is a postnatal one. So this was on day 3 post-birth. And her blood pressure was 161/101. And again, at News 2, score of 0. She had a seizure en route to the hospital, and she had postpartum eclampsia and an intracranial bleed, and required extensive rehab, but did eventually make a full recovery about 10 months later. So what is this tool that I'm talking about? So the first part of the tool that we've created for JRCALC is the parameters. So these are the parameters that you would take on all pregnant patients, on all patients as part of your primary assessment, and we would recommend that you take them on all pregnant and recently pregnant patients. So you can see there you've got the low parameters and the high parameters, and you've got a different pulse rate from 48 hours after the birth onwards. This tool is to be used from the point of conception to 4 weeks postnatal. So 4 weeks after a baby loss or a live birth or a stillbirth or any pregnancy, so a termination of pregnancy as well. So these observations should be used in all of those circumstances up to 4 weeks, and they should be used on every patient. And as I said, it could be pregnant, recently pregnant, or suspected pregnant. That's when we would recommend that you use these parameters. The next part of the tool is our various red flags relating to the things that you can see on the screen. So consciousness, cardiac symptoms, abdominal pain, symptoms prior to 20 weeks pregnant, and then PV loss less than 20 weeks. And we'll come on to a few more that are on the tool. So really we're trying to, as you can see here, in pregnancy, a respiratory rate should not be raised. So they might feel out of breath, but actually the rate should not be high. And we definitely need to take chest pain seriously because of things that we're going to discuss shortly. And in terms of abdominal pain, so we're talking about preterm labour here, and noting that in the imminent birth guideline, it states about the fact that preterm labour, it's often presenting, it can present atypically. So rather than having strong regular contractions, it may present like that, but it may present just as like period pain or intermittent back pain. And so any pain or contractions in the abdomen or back pain or regular kind of pain should be considered as preterm labour. And with preterm labour, why it's a red flag here is because it's not necessarily, I mean, if the birth is imminent, obviously that is very much a time critical situation. But it may be that if we can get this woman to hospital in a timely way, then there's more opportunity to provide her with steroids for fetal lung maturation, or magnesium sulfate for neuroprotection, or both ideally, and antibiotics. They're the kind of 3 drugs that we give to all women in established preterm labour. So the sooner we can get the woman to the hospital for those interventions to start, the better the outcome for that preterm baby. Any constant abdominal pain, and we're referring there to things like abruption, uterine scar pain, of course, at any gestation. If they've had a previous cesarean section, that should be a red flag if there's uterine scar pain. With regards to symptoms prior to 20 weeks, we are really wanting to exclude ectopic pregnancy, and thinking about the fact that, yes, she might not be showing signs of shock yet. But if there's symptoms of ectopic pregnancy, they need to be considered. And in terms of PV blood loss less than 20 weeks, I would refer you back to the guideline that I mentioned earlier. But essentially, we know, sadly, that within a miscarriage or a termination of pregnancy, there will be significant blood loss. However, we obviously don't want that to be too much blood loss, which is going to put the woman at risk at home. And this tool doesn't tell you what to do with regards to labour pain over 37 weeks, which would be term labour, and we would urge you to refer to the imminent birth guideline for that. These are the other red flags. It's all on one continuous page, but I wouldn't be able to fit it all on one slide where you could vaguely read it. So that's why it's been split up. So PV loss, more than 20 weeks pregnant. So under the red flags here, any fresh red bleeding, and that's, as I said, get up that algorithm. It has it all there. It's reported by the woman or seen by us. Any blood-stained amniotic fluid, meconium-stained waters, which will come out green, and that's because that can be a sign of that the baby's not happy. It could be a sign of fetal hypoxia. Offensive smelling waters because of the sign of infection, and waters broken under 37 weeks. So again, that is so that if the birth was to continue to happen, then we would have the chance to provide those medications that I mentioned earlier for fetal, for prevention of infection, for neuroprotection, and for fetal lung maturation. In terms of PV blood loss postnatally, I would again refer you to the postpartum hemorrhage guideline. But in terms of the longer term postnatal period, if the woman is having offensive smelling lochia, lochia is PV blood loss in the postnatal period, then that would be a red flag. In terms of preeclampsia and eclampsia, these have been taken from the NICE guidelines, essentially lifted directly to the symptoms that we would have as red flags in terms of midwives and obstetricians in a hospital setting, and you can see those there. And in terms of neurological, I think everyone would be clear that an active seizure would be a red flag, but it's also a history of a recent seizure. So if she's saying, or a family member is saying that there's been a seizure, that, you know, but now that it's all terminated and she's well, we would still recommend that she needs a time critical assessment. And of course, if she looks unwell, this tool should absolutely be used alongside clinical judgment, and it's not to take away your clinical judgment by giving you this tool. There might be additional concerns voiced by the patient, the family, or a clinician, and they should always be considered. Of course, language barriers we've talked about before in terms of the inequity that exists for women that don't speak English as their first language. This tool doesn't tell you what to do if you've got mental capacity concerns, or if the woman declines transport. You need to follow your local protocols for that, and for safeguarding. So essentially, you'll follow local guidelines in terms of where you're going to take this woman, and also with regards to pre-alert. Most of the time, for over 20 weeks in a maternity unit, if there's red flags, it's helpful for you to pre-alert them. And noting that a pre-alert is a one-way conversation to let them know that you're coming, and not a full clinical handover. In terms of ongoing observations, you can see there that if there are red flags, we would like repeat observations and for those to be documented, or in some trusts I know that you can do a print summary on the life pack, or whatever equipment you have. Again, I would say you need to use your clinical judgment here. So if, for example, if you've got a lady at 16 weeks with a temperature of 37.5, you may not travel on blue lights and sirens in the same way that if she was 38 weeks having eclamptic seizures, with a high blood pressure. So you need to apply your clinical judgment, and this tool is not telling you how to drive to hospital. That is a separate thing that you need to think about, a separate decision, and share that decision making as you would with every other patient. This is about identifying what is normal in a pregnancy and what is not normal until everything else is excluded within a hospital setting. This tool is telling you which women require an assessment in a maternity unit and where that might be time critical as well. So essentially, where it comes into use, we want you to, whenever attending these women, we want you to get it out. It's used on scene, and then that is going to hopefully add to your decision about and what care you provide to the woman. So we want you to use it and then act on it in a timely way so that the assessment can be timely. And in general, you're going under 20 weeks to ED and over 20 weeks to maternity. But again, that might vary across different regions. And in terms of a pre-alert, if you're going to ED, for example, you may not pre-alert. It would depend. You would often pre-alert just based on what you would do for a non-pregnant patient. But as I said before, over 20 weeks to a maternity unit, if there's any red flags, then pre-alert. So I'm just going to run through a case where the tool has been used. So this woman's in labour, no urge to push, but she's vomiting. The ambulance clinicians take observations and a history, and this is the history: 39 weeks, uneventful pregnancy, contractions started 6 hours ago, no urge to push, and she's vomited twice today, and she feels unwell. So you can see here that ordinarily without the tool, we may actually not be that concerned, not overly concerned. We might not be rushing with this woman. But then we take the observations, and you can see here a couple of sets. So on the left here, I've identified there where the red flags are. So she's got 2 red flags of arrests of 26 and SATs that are 94% on air. And her News 2 score wouldn't be significantly raised. Pulse 115, which is an amber flag, and normotensive and not a pyrexial. And you can see there that they've added then oxygen, and her SATs have come up, but she's still got a high respiratory rate. So in this case, they did use the tool. This was in a service where they already have the tool, and a pre-alert was put in. So in terms of a pre-alert, I know that this varies across the country as well. Sometimes it goes through the control room, sometimes it's a direct conversation. If it was a direct conversation to the maternity unit, this is what I would expect you to say, just the headlines, that you've got a patient in labour with contractions at 39 weeks. And then your assessment is telling them what is raised in terms of the red flags. So we're not saying she's got 2 red flags and that's why we're bringing her. We're saying she's got a high respiratory rate and low saturations requiring 2 litres of oxygen and a high heart rate. And we're coming to labour ward now, and the ETA is 20 minutes. So in this case, the tool meant that they identified very quickly that this woman had red flags, extricated and transported very quickly, 12 minutes, and observations were done every 5 minutes en route. This was arrival to labour ward. Her respiratory rate has gone up even more. She's got a higher oxygen requirement, and now she's got a high temperature. So we often see this with sepsis. So where they actually don't get a pyrexia till almost like the last minute. So the baby required full resuscitation. The mother was septic and required transfer to ITU. The baby and mum were reunited on day 5, and they were both in hospital for 12 days total, and both had a full recovery. And we obviously can't unpick all of the multifactorial things that come into all of these cases, but being swift to identify a woman that was deteriorating was really key in this case. And there could have been many differentials, I'm sure you agree, when they first arrived. And what we've sometimes seen is where the differentials could be PE or it could be anxiety, and we go towards treating them like they have anxiety. And then in this case, it was actually sepsis. So I've kind of started to reflect on this already, but in terms of respiratory rate, this will be your most important observation. It shouldn't be raised in a pregnant woman. Don't ever make excuses for it. Don't say she's in pain, she's in labour, she's anxious. Yes, it could be labour, but it could be any one of these pathological reasons as well. Peripartum cardiomyopathy, it could be a PE, could be anemia, could be pulmonary edema, sepsis. It could be new onset asthma, although that's rare in late pregnancy, pulmonary hypertension as well. Just in terms of sepsis, babies exposed to infection in utero are 5 times more likely to get cerebral palsy. And if we add a hypoxic injury to that, they're 72 times more likely. And this tool is really important to make sure that we keep mums and babies safe. So whenever they're pregnant, suspected pregnant, recently pregnant, we're hoping that this tool will allow you to convey with confidence. Don't rely on your memory. Remember postnatal women. And it's just for ambulance clinicians. It's not for midwives or obstetricians. They will have their muse that they can use. And what about calling a midwife? So there have been multiple cases within the UK where ambulance clinicians have identified red flags on scene, but then they've called a maternity unit, and then that has led to either a delay, a de-escalation, a misunderstanding of the pre-hospital setting and what we have access to in terms of monitoring and diagnoses, and also documentation, which is limited due to the electronic notes. There's also a problem with governance because those calls are not recorded. We're reliant on the midwife to document what was actually discussed, for example, and we have this has led to patient harm. So I would recommend that you use the tool and if you identify red flags, then act on that rather than checking that they are red flags. So it goes live on the 21st of October. There'll be lots more stuff coming out about this, but we've got this webinar recording, obviously, and there'll be further information disseminated to maternity services and to the healthcare system, bearing in mind that they will not be as familiar with it as you now, having attended this. But we are doing work to disseminate information to EDs and maternity services. There will be an ongoing audit by ambulance services, and we're working towards integrating it into EPCR systems. So I'm going to pause there. We've rattled through. What I'm going to put up now is the Mentimeter for any questions. Thank you so much for coming today. You will get a certificate of attendance to your email that you used to register. If you want to just use that QR code, or you can log on to Menti and put in any questions. We've only got about 10 minutes. However, we will do our best to answer any questions. I can see Darren's got his hand up. Do you want to just take yourself off mute?
Sorry, yeah, there was a couple of questions, some of that you've answered already. The APGAR removal, are hospitals going to be made aware of that?
Yes.
Requesting an APGAR, we say we don't do that anymore. Are they going to be made aware of all that new information?
Yes, that has been disseminated formally from AACE, who hold the JRCALC guidelines, as in it's within the update. We are holding a webinar for maternity services, and that will be included in there. But essentially, APGAR is a retrospective way of documenting something. So, you know, how the baby was at various points. It doesn't inform your clinical decision making at the time. So yes, maternity services may still want to talk you through what was the APGAR, but that can be done retrospectively at the time of handover.
Great. And the last one was you mentioned the changes to the observations. Would there be any change to blood sugars when for pregnant? Would the normals be different for those? I know that I've heard something, but it's a while since I've done it.
Yeah, we actually decided, the task and finish group actually decided not to put in the blood sugars there because that actually varies according to the woman, in terms of like if she's got diabetes or she hasn't. So we would be guided by what is normal for the woman. But in general, you use your normal adult parameters.
Brilliant. Okay, that was it. Thank you very much. And thank you for today.
No worries. Thank you. And Rachel?
Hi, sorry, I was trying to use the QR code, but my phone doesn't want to play ball at the minute. Just a couple of questions. I know obviously the update, we only have to wait until Monday for that to go live, but is there any way that I can get access to the maternity decision tool prior to that? Just I have a meeting with our training department this afternoon, because I think the only version I have is the draft version. So if we have a finalised version, just so they know what is coming, that would be useful.
Yeah, which trust are you, Rachel?
North East Ambulance.
Oh, brilliant. Yeah, it's on Basecamp, and Dan Howarth has access to that.
Fabulous. I shall link in with him. And my other question was, when we incorporate this into our training package, your case studies are anonymised. Would you mind if we use them as examples, just to show how News 2 isn't appropriate?
Yeah, that's fine, because there's no way that anyone can tell from what I've said there, because there's actually so many cases that we could have used. So yeah, that's fine. Whatever's in this webinar you can use, and it's being recorded and will be published, available. Yeah.
That's brilliant. Thank you very much.
And Rick?
What you've put into this, it's I mean, it's clearly quite extensive, and I just want to say thanks for that. Just a very quick question. The Muse tool, is there going to be an interactive app developed in the same way that News has one. It just makes it extremely easy for junior clinicians to use, I think, rather than going through a sheet and coming to their scoring.
Yes, well, essentially each organisation will be eventually integrating it into the EPCR, but and there will be an e-learning package that we're going to produce. But yeah, I don't know if others, Dawn, Susie, Gavin, feel free to comment.
I was just thinking that sounded exciting, so I wonder if you might put your email in the chat and you can enlighten me, because I don't know what it is, but it sounds good.
Okay. Thanks.
Thank you so much for those questions. Thank you. And thanks for all the comments and questions in the chat. I'm just going to go to a few in the Menti. So, apologies. The table shown, did you say they're to be used from conception to 4 weeks post-birth? Yeah, absolutely. I'm going to bring Susie and Dawn in for this question. So in newborns, preterm birth, can you confirm safest way to travel? You mentioned avoid car seats if possible, and if necessary for interventions, would you say the smallest harness is adequate? I think it's a regional thing, but what do you?
Yeah, do you want me to take this one, Susie, and then you can chip in? Okay, so this is always a real challenge because ultimately we don't have anything for preterm babies. So I always teach our crews how to package the baby, basically to bulk them out a bit, so that you can then put them in that harness. It's not ideal. It's really not ideal, but it's the best that we have available at the moment. Susie, do you want to add anything?
Yeah, just to add, I think a lot of ambulance services are looking at equipment at the moment in order to be able to transport newborns from very, very small ages to and cross-reference those. We'll actually have a cross-weighting so that we've got paediatric harnesses already, and so there might be some crossover between bigger babies and newborns. But we are looking. Most ambulance services are looking at methods to utilize equipment in order to be able to safely transport newborns and even preterm babies as well, considering the fact that we'd also need to keep them very warm. So it's in the addition of using the transwarmer, we need to ensure that these babies are safely secured to the trolley. It will bring its additional challenges. We already face those challenges now because we've just recognised the fact that not every ambulance service has access to all this equipment. It's not something that's bypassed us, but at this moment in time, what we do know is that every ambulance service is looking into it.
Thank you. Yeah, and there's the national group. There's a equipment subgroup that's looking into it, and it's on the National Risk Register for ambulance services. The fact that we don't currently have something that's that covers everything.
Camella, I've noticed. Sorry, I beg your pardon. I've noticed another question about temperature management in the chat. Are you happy if I just address that one quickly?
Yeah.
Yeah. So we've now got the out of hospital NLS course, which you may or may not have heard of, but that is now it's not live on the website yet because we're still a very small faculty and we're going around the country trying to grow that faculty at speed. But as part of that piece of work, we did do a minimum standard equipment list for all ambulance services, and that did include a thermometer. So do not worry if you don't have one, because actually I think there's very few of us that do, and we're all looking to see what's the best way of trying to purchase or procure a good cost, and how we monitor it and when. So that's another piece of work that's coming.
Thanks so much, Dawn. And just to say, it does say it in the care of the newborn guidance, which was updated more than 18 months ago about temperature management, and also it does say it in the imminent birth guideline as well, the new imminent birth guideline about temperature and about monitoring, when we would advise monitoring a baby's temperature. I've just got a couple more questions in the chat. So meconium stain liquor, does it mean hypoxia? Not in every situation. However, in the pre-hospital setting, we're not able to exclude that as a reason. I hope that makes sense. So there are physiological reasons for meconium stain liquor, water, amniotic fluid, but we're not able to say if we see it in the pre-hospital setting whether that's normal for that particular baby or not.
There's another one here, Cam. which might
Go
be
for
one
it.
for you,
Yeah.
actually. Will the maternity details in the sepsis treatment and triage tool be removed?
So what we're recommending to each region, if I understand the question correctly, is that they take the time to ensure that the sepsis tool directs people to the maternity decision tool if they're pregnant. So essentially, like, for example, where this has already been used on the sepsis tool, it says do not use this if they're pregnant, and also on the pediatric one, because, you know, sometimes there are people under 16 who are pregnant. Oh, I think somebody is not on mute, but hopefully that answers the question. If you can, if the person asking that can just say whether that's answered the question. We are planning to create a toolkit which will be circulated to the different maternity leads that sit on the national group for dissemination within each ambulance service. All 13 ambulance services across the 4 nations are represented on that. So we will be sharing that toolkit in due course, and the PowerPoint from today will be included in that. What I will just say is that we've now reached 11 o'clock, so I want to say a massive thank you for joining. If you could just do the evaluation form that I've posted on the screen, then that would be really, really helpful, please. I will also send it around via email with your certificates. This is just because this is our first time of doing a national webinar based on maternity JRCALC updates, and we'd really love to hear whether it's been helpful, what you need more of, what you need less of, and how we can support you. I will also post in the chat for people that are from EDs and maternities, maternity units, so that you'll have access to the webinar that is going to be on the 27th of November. And the final thing I'd say is that I did post in the chat further up a YouTube video that has a full webinar on the new imminent birth guideline. And thank you so much for coming, and have a wonderful day. Please don't forget to do the evaluation form. It will only take you approximately 90 seconds to do the whole form. So please fill it in before you leave. Thank you so much, everyone. Last word from Susie, Dawn and Gavin.
Just thank you for all attending. It really makes the difference, so you can go out and spread the word. Thank you.
Yeah, thank you so much. Really good that we've had representatives from across the 4 nations in the chats and in the meeting. So yeah, please do sort of disseminate this down to all your local staff and colleagues.
We really do.
Thank you so much.
Useful. We've all, you know, the contributions have come from people who work pre-hospitally and in maternity and obstetrician, you know what I mean? So it's a real collaborative approach, and we really hope that you find it useful. Thanks for today.
Thank you, everyone, and have a lovely weekend when you get there. And we will be in touch with further information in due course. And yeah, please, any take-home messages that you've got from today's webinar, please tell at least 20 of your colleagues so that we can spread the word.
50 colleagues.
I'm just going to put the links in the chat, so they're coming now.
Cam, lots of people asked for the presentation, so I don't know if that was a possibility.
Yeah, the recording will be available, and the presentation will be available within the toolkit, which will come out once it's finalised.
Okay,
thank you,
fantastic.
Dawn. And thanks so much, Dawn, Susie and Gavin, for presenting today. Yeah, and for all your work on the guidelines, and all of the other people on the National Leads group that have been involved in the guideline productions. Amazing teamwork from across the country. And I'm just posting, somebody's asked me to post the YouTube video again, so I'm posting that now. And yes, thank you as well to JRCALC and AACE for their support with these guidelines. Okay, have a lovely day, everyone.
Bye.
Bye.